NDARC webinar. My name is Kriana Barat. I am a research fellow at the National Drug and Alcohol Research Centre and co-chair of this webinar series, where we aim to highlight national and international work from experts from the field of alcohol and other drugs. I'd like to start by acknowledging the Whadjuk Noongar people, who are the traditional custodians of the land from which I work upon. It is a privilege to be tuning in from Whadjuk country. I'd like to extend that acknowledgement to the traditional custodians of the lands that you all may be gathering on today, as well as elders past and present, and any First Nations people present here today. Now, it is a pleasure to introduce today's speaker, UNSW's own Associate Professor, Sally Nathan. Sally is a combined track academic with a research program characterized by the use of multiple methods to examine complex psychological, behavioral, community, and socio-political changes. Her research has focused on a variety of topics, including consumer community participation in health service decision-making and governance, and most pertinent to today's topic is adolescent drug and alcohol treatment. So in today's webinar, Sally's presentation will present results from the Youth Pathways ARC funded study, with results examining mortality, hospitalisation and convictions data, as well as a discussion of the experiences of Aboriginal young people in mainstream programs. I am pleased that during the Q&A session, we will have the opportunity to hear from Dr. Phil Clare, biostatistician for the Prevention Research Collaboration at the University of Sydney and an adjunct lecturer here with us at NDARC. Sally and Phil will take questions from the audience after the presentation. I'd ask you to please log those questions using the Q&A function, and I will relay as many as possible to the speakers at the end of the presentation. With that, I'll hand over to you, Sally. Thank you.
Thanks, Kriana, and thank you everyone for having me. It feels like this study was completed a while ago, but publications were through to 2023, so I guess it's not that long ago that we were still analysing and writing up. I'd like to acknowledge the Ted Noffs Foundation, who were a partner in this ARC linkage grant, without whose support for this important work it wouldn't have been possible. So we looked at experiences and pathways of young people in residential drug and alcohol treatment programs, and it was a mixed method study. I'm having trouble, there we go. Even though there's been an acknowledgement, I would also like to respectfully acknowledge traditional custodians and owners, and that sovereignty was never ceded. This is La Perouse, which I live quite nearby, so I'm joining you from Bidjigal lands, and I want to pay my respects to elders past and present, and the deep feelings of attachment and relationship that Aboriginal people have to country and their incredibly rich culture, which has driven a lot of this research with really important Aboriginal academics and young people from Aboriginal Torres Strait Islander Aboriginal backgrounds. The cultural authority of Aboriginal and Torres Strait Islander people is so important in work where they are overrepresented in client groups, and I'd like to acknowledge any Aboriginal and Torres Strait Islander people online today. So really big team, and I just, bit of a caveat here, I'm not a biostatistician, I didn't do the stats. Andrew Hay and Tyson Witten were two of the main drivers of that, but a range of people involved in the project, including the wonderful Megan Williams, who's Wiradjuri, and Bianca Martin, who was a young Aboriginal person who became a peer researcher and worked with us. So it was a linkage project. We had a really fabulous Aboriginal advisory committee, and a shout out to Michael Doyle, who was a major force on that committee, as well as a number of other people. A lot of data custodians that gave us access to data after a lot of ethical wrangling, and the NOF staff, but also the young people themselves who, in particular, through the qual work, shared their stories with us. So I'm going to give a background to the study. I'm then going to I've picked a number of bits of data to share, which I hope are of interest. Looking at the mortality data, first of all, some of the hospitalisation linked data, convictions, and then I really want to hone in on Aboriginal young people's experiences, because they represent 40% of the young people referred to the Ted Noffs residential treatment programs. So We did this study because there wasn't a lot of high quality outcome studies focused on residential treatment outcomes for young people internationally, in particular using mixed methods. So we wanted to examine the experiences and the outcomes of young people who participated in a program called PALM, and I'll give a quick overview of what PALM is, compared with similar young people who had not completed the program. And as always in these studies, finding good comparison groups or control groups was tricky. So PALM stands for the Program for Adolescent Life Management. And what that signals is it's not just about drug and alcohol use. The program looks at whole of life, the social determinants, employment, education, all of the things going on for young people. So it's a modified TC, therapeutic community. I don't really have time to tell you much more about that, but the community is a major agent of change in that peers can influence each other, usually positively, but the staff have a much greater role in an adolescent therapeutic community than an adult one. So it's based on the eastern seaboard of Australia. Programs run out of Canberra and Sydney, although some of the analyses are just on Sydney, and TEDNOFS is a leading NGO in the sector. So the young people in the program are aged 13 to 18, but some can be younger, and they're experiencing difficulties relating to problematic alcohol and other drug use. They come, even though it's in Sydney and Canberra, they come from all across urban and regional areas from the eastern seaboard of Australia. And NOFs have now got some other programs in Canberra. They've also got a program called CALM, Continuing Adolescent Life Management. So they engage young people with another separate team to the residential team that start early on to talk to them about what's going to happen when you leave. So the program is up to 3 months. So they begin really early about what do we do for that continuing care so that you don't leave and all of a sudden there's no supports for you. So the study that we did had 3 main components. We combined existing data from using a linked data approach from data custodians, administrative data, and the TEDNOFS data about young people who'd been to the program. We did a survey, which I'm not going to be talking much about today, just a little bit, and in-depth interviews and some other participatory qual research with young people and staff. So the linked data I'll come to first. So we had records for over 3,000 persons from a cohort of 3,639 referred from 2001 to 2015. The thing that really stood out for us was even though they were still quite young at the time of the study, they came up in a lot of health data sets. So nearly 80% in emergency, for example, and nearly 60% in criminal justice data sets. So we took data from pre-referral, so from age 11, so back in time before they were referred from the admin data sets, up to 15 years post-treatment. And obviously that varied depending on age and referral date. So the mortality data analysis, I guess, in some ways was the easiest to do because it's using quite, just straightforward variables. It was quite depressing, I guess, in a way, but probably drove us to want to look at a lot more of the data with a lot more gusto. So we wanted to look at mortality of the group that were referred and compare with the general population, obviously standardised by age and gender. So we wanted to look at mortality around demographic, treatment, use, mental health, and so on, and to look at the cause of death. So it was a retrospective cohort study linked to mortality data, and we followed up to 16 years until December 2016. So what did we find? We found a really significantly elevated standardized mortality ratio, the last column for males and females, and you can see it's 9.6 times for females compared to the age standardized group in the general population. And also, and I think that's really was pretty alarming. And I don't like the word Indigenous, but it was used by the student in the table. But Aboriginal young people elevated, but also same for non-Aboriginal young people. Those that didn't attend had lower, but we think that's because the group that do attend are the ones that have maybe more complicated mental health, maybe their severity of dependence scores, which were higher. So there's a range of reasons for that. And the non-attender groups that are referred, so they've got data for them, but they never end up attending the program. So that became one of our key comparison groups, as well as looking at those that complete versus those that don't complete. So given our sample size, it's probably not surprising that we didn't have you know, the difference between non-complete, complete and non-attend was not that stark. So it was really more of a descriptive analysis in the end that was really interesting. So drug or alcohol as an underlying cause contributing were pretty large proportion of the deaths. So these are deaths that are quite strongly related to drug and alcohol related issues. And even if you look at the non-drug and alcohol related deaths, suicide and transport, you can see how drugs and alcohol may have had a part in some of that, even if it wasn't documented in the actual certificate of death. So what does that mean? There is a higher rate of mortality in this group, whether they attend, complete, don't complete, compared to the general population of the same age. Many of them that died were aged below 24 years. So we're looking at a significant loss of life really early, and that future of that young person, not, you know, and the impact on family of someone dying so young. Comorbid mental health and a history of trauma are pretty significant in this group. So we would probably expect an elevated rate of mortality. As I said before, those in treatment may be more likely to have higher comorbid mental health issues at baseline, and we did find that, than those who did not attend. So they're more at risk even if they do come to treatment or not. Drugs and alcohol, obviously remaining an issue. But I guess the take-home message for policy and the clinical context is, you know, post-treatment, that CALM program that TEDNOFS runs, and I know they've ramped it up significantly since the data from this study. We really can't just say, oh, well, they've gone through treatment, job's done. And there's been a lot of obviously debate in the literature about what should continuing care look like. But it's vital that we connect young people to services, maintain support with them to minimise relapse and reduce risk of harm, including death, often related to drug and alcohol use. So there's not enough funding of that kind of continuing care. Turning to hospitalisation, and all this data together tells, I guess, a bit of a similar story, but there's some interesting side paths as well. We looked at the rate of hospitalisation. So we had data on hospitalisation for ACT and New South Wales, but this analysis was just on the Sydney data because it was more robust. There was some issues with the ACT data. So we looked at rate of hospitalisation for physical injury, mental health, substance use disorder, and also organic illness up to 15 years post-treatment. So we looked at all adolescents admitted to PALM, but because we had Bureau of Crime Stats data and the leading person, Tyson Witten, and a shout out to Tyson that he just did some amazing work with this data set. He wanted to see whether, you know, what was happening around those with and without a history of a criminal conviction. So again, pretty similar sample, 3,500. Oh, no, actually was the ACT. Sorry, this analysis did keep the Canberra people in it. And the New South Wales PALM between January 2001 and 2016. And we ended up with almost 1,800 who were still alive during the observation period and born before 31 December 1998. So just to tell you that the characteristics of the sample, and this is characteristic of the PALM treatment group more generally, is males are overrepresented in the sample. Some of the reason for that is historically there was more male beds than female beds in the residential facility. That's changing now, but at the time there was definitely less females, and they didn't even have, you know, people being able to identify as neither male nor female. So there's been quite a bit of change since. As I said before, over 40% Aboriginal and or Torres Strait Islanders, so massive, large numbers. And that doesn't mean that there's more problems. It's just that maybe this type of resi treatment works for Aboriginal. It's something Aboriginal Torres Strait Islander young people want to go to. Maybe it's because of the over-incarceration and over-policing of Aboriginal people, because quite a lot of referrals come from the justice system, but they're definitely overrepresented. And as you can see, the criminal convictions really high, and that's across the whole program, coming in around 16 years of age and using on average up to around 3 different drugs. I'm not going to go on too much about analysis, but just to let you know that we compared in this particular analysis those who stayed in treatment for greater than or more than 30 days. And that's seen by the program as kind of a bit of it's a bit arbitrary, but it's a kind of, you know, this is about when we start to see change, but could be critiqued on that as just an arbitrary number, but comparing to those who stayed less than 30 days. So we use the admitted patients data collection, and we use the box R to look at covariates. So it was controlled for various things that might have driven the data that wasn't the main outcome we were looking at. So lots of wonderful statistics. So the main analysis was propensity score matching, which was try to make those two groups of less than or equal to 30 days, less than 30 days or greater than and equal as close as possible on all of those covariates. So we ended up with 633 matches. So altogether 1,266 bits of data. And then we examined using Cox regression. So this is called a survival analysis. So how long does the person, last until they hit a day that they're admitted to hospital? So that's how I want you to look at these graphs. So all the regression analyses that were done were adjusted with the propensity score. So what you can see here is that the blue is the treatment group and the red is the comparison. This is about a substance use hospitalisation, and you can see from the slope of the line that it takes longer for someone in treatment to be first hospitalised for a substance use disorder. So of those hospitalised, it took longer for those in treatment, meaning that they survived before getting into treatment. So there's less hospitalisations and less quickly for those who've been in the treatment, and not everyone ends up in hospital for substance use. But there was no difference between those with a conviction and without, which isn't graphed, but it's on the side in the right stats. Similarly, even though it doesn't look like it, there was actually a difference between treatment and comparison on physical injury. So again, those who'd been in treatment were less likely to be admitted to hospital for a physical injury, and it took longer for them generally on average to do so. And there was a difference between prior conviction and no prior conviction. So those conviction more likely. Mental health disorder, similar type of pattern. So what does it mean, all of these wonderful technical graphs? It means that treatment in PALM for greater than or equal to 30 days was associated with a lower rate of hospitalisation for all diagnostic categories we looked at. Treatment conferred a significantly greater reduction in rates of physical injury for those with a history of criminal conviction, which kind of feels quite logical because there's often a lot of affray and other type convictions for these young people. They get into arguments and fights and things like that. The treatment effect we, hypothesize is due to PALM's focus on a lot of the social determinants. So, the impact on things beyond just substance use is a function of the really holistic way the treatment program operates, and a lot of focus on broader mental health, social skills, and so on that might flow through to hospitalisations. Again, aftercare or continuing care. And again, the high proportion of Aboriginal and Torres Strait Islander young people in this program highlights how there needs to be more attention in the sector more broadly as well about culturally responsive models of care. So I will turn to that at the end. We can't generalise this to all young people. This is about young people with a history of substance dependence. So the convictions linked data analysis, this is where I think, we've done some quite novel work. There's not been as much work done with the Bureau of Crime Stats data with young people in treatment. But given this group has got a lot of criminal convictions history and criminal justice involvement. So we looked at a number of things. So this is an analysis looking at the effect of treatment at age 17 on subsequent convictions over 5 years following referral of young people. And we got them into different offending or conviction trajectories. So we it was a type of modelling that Tyson and the team did. And then we looked at those distinct offending trajectories and what they meant. Because there is a number of young people, quite a large proportion, that come in with absolutely no history of criminal justice or, convictions. So we only looked at the Sydney program for this analysis because we had New South Wales Bureau of Crime Stats data. And we looked 5 years follow-up. And again, this is a different break in the numbers. We looked less than 3 days, including those that never came, and greater than 31 days in treatment. So again, we did some matching, we did some controlling for a number of things that might impact criminal convictions. And we also controlled for when the young people might have been, when they were actually incarcerated because they weren't in the community and weren't then able to be convicted of a crime. So this is prior to referral, which is pretty alarming that by the age of 14, 15, in the high level offending group, on average, they're being convicted 3 times before they've been referred from the age of 10. And so it's pretty concerning if they continued on that trajectory. The drop off at the end in the red line, don't worry too much. It's a little bit of an aberration in the data, but we had 3 groups. We had a no offending group. We had a low level offending group that were, involved in some convictions. And then we had this high level offending group. So we looked at these 3 trajectories in the analysis. So what we found was that there was only a significant difference in convictions post-treatment in this high incline group on the far right. So this is a box plot graph, but that was the only one with a significant difference. So what does this mean? So staying in the program, in this case, we did 31 days or more, was associated with a significant decrease in convictions for a group that was on a trajectory of high incline convictions relative to young people who spent less than 3 days in the program. And in my view, 3 days in the program is just getting settled. They don't really get much access to treatment or support. The reduction in the number of convictions for the high incline group is substantial. So we've already presented this to Department of Communities and Justice about 2 years ago. And, they've used some of this data, I hope, to inform some of their work and what they fund, but an average of 4.36 fewer convictions over 5 years post-referral for this group of young people. And we did some sensitivity analysis. So again, what I think is really important here is not only do these therapeutic communities have potential to reduce classic kind of health outcomes like hospitalisation, they also appear to be pretty effective to reduce convictions in the future among young people with drug and alcohol problems who also have a high number of convictions prior to referral. And this is really important because these young people are still in the juvenile justice system. And what we don't want to happen is for them to tip over into the adult criminal justice system. And it's been very hard to track these young people in previous studies without linked data because you can't go back to that data. They become disconnected from the juvenile to the adult. Okay, so that's some of the linked data stuff that I wanted to share. And there's a lot more. I've got a whole list of papers at the end, please, hope you might have a look at them, follow up with myself or the lead authors. Really happy to give any further info you want to know. But for me personally, I guess one of the areas of the work that I was most involved with and most passionate about was the research we did with Aboriginal young people. And it still remains a high priority area for attention and for working with community to provide the right kinds of support for Aboriginal young people who do end up having issues with drugs and alcohol, and many don't. So a bit of data we're sharing. This is Koori Voices, a paper I wrote with Meg Williams and other colleagues looking at the 3-month follow-up data. So this isn't the 12-month data. That was really problematic and we're still to publish it. Not sure I ever will. Incredibly difficult to follow up these young people post-treatment. It was one of the hardest survey studies I've ever done, but the 3-month is a lot easier because this is a regular kind of survey that NOFs have been doing for a long time. So young people who stay more than 30 days are surveyed as part of routine. And because they've stayed 30 days or more, they've got a relationship with NOFs. So when someone contacts them for a survey, they're more willing to do a survey than if I contacted them through my team at UNSW and they're like, I don't even remember going to NOFs. So definitely the response rates are better, but still challenging. So this was looking at Aboriginal young people admitted between 2007 and 2016. There were 1,619 that were admitted. 247, so much less than half, stayed 30 days or more. 89 were able to be followed up at 3 months, which is a 36% response rate on those who stayed. So this comes again for the whole data set. This isn't just about Aboriginal young people. There is a high level of disadvantage caused by structural things that have happened to these young people, probably from very early in life. What I think I've made stand out here in the red is that we looked at number of places they'd lived in the past 6 months, which is recorded at their baseline referral assessment. So in my view and the view of the team, living in 3 or more places in the past 6 months suggests unstable housing. So 21 of the 59 males and 16 of the 30 females that we talked to had been in 3 or more places. So it's really alarming. And obviously in the current status we're in Australia and Sydney, it would be even worse. Court involved again, really high levels of court involved, but higher for males. So males 50 out of the 59 and 17 out of the 30 females. So yeah, so disadvantage. And, when we looked at some of the other data as well for the whole group, a lot of them had been expelled or suspended from school. So again, we're seeing this sort of compounding disadvantage that society is, the structural determinants, the social determinants, lack of opportunity, etc. So the analysis we did here, we had a severity of dependence scale. We had some other scales, family assessment and a social functioning that didn't show change, but this is pre-admission to 3 months. We showed an improvement in severity of dependence in the group followed up, a reduction in alcohol and a reduction in polydrug use as well. The thing that we ended up focusing on in this paper was self-harm and suicide. So what was really, really significant was that this is a Wilcoxon cross, can't remember the full statistical name, but it's people are moved between different yes, no. The thing to look at here is that 18 young people moved from yes, attempted to end life in the last 3 months, to no at 3 months post-discharge. And similarly, 23 young people moved from yes, self-harmed in the last 3 months, to no. Even though some no's moved to yes, they're very small numbers compared to the other way. Similarly, with arrests, we saw at pre-admission, we had a big reduction in those that said they'd been arrested 1 or more times. There was 47% or 39 to 24 post-discharge, 28%. So again, seeing reduction in arrests, and these were statistically significant. So again, key findings. What we found with this group, and obviously it's not representative of all the Aboriginal young people who came into the program, and also, not of all of those, because we couldn't even follow all of those up that stayed 30 days or more. But nonetheless, in the group we were able to follow up, there's obviously a significant decrease in self-harm and attempted suicide post compared to prior. Fewer reported using cannabis, amphetamines and alcohol. The polydrug use, number of drugs significantly reduced, as did severity of dependence scores. The arrests prior to admission compared to 3 months post, again, was significant. But one of the questions that remains for me, and one of the reasons for some of the qualitative work we did, is how do we prevent significant numbers of these young people leaving before 30 days? So something's happening for those couple of hundred Aboriginal young people who get referred, who leave. It also happens for the other non-Indigenous young people. It's a challenging thing to go into a program when you're 16 or 17 or 15 or 14 and be expected to stay for up to 3 months. So there's limitations in this work, as I said, lost to follow up. But one of the things that was important is we did do a comparison between the baseline data of those we followed up and those we lost to follow up. And we found no differences on some key socio-demographic measures we had, except that a higher proportion of young women compared to young men completed the follow-up as a proportion. And also the measures we used were not developed specifically for Aboriginal and Torres Strait Islander young people. So some questions about the cultural appropriateness of some of these measures. Particularly around the family, I might note, because family structures and systems are very different for different communities, and Aboriginal and Torres Strait Islander communities have quite a different conceptualisation of family than us colonial peeps who've developed a lot of these measures. So I wanted to end with some really important lessons and things to think about that our research and much other research being done is telling us about health systems. What are the critical things when we have a program that's providing a service for Aboriginal and Torres Strait Islander people, in this case, young people in a residential program? How do we understand the experiences of these young people so we can inform service improvements and maximise impact? So some of the work we did, and this isn't all of it, but I wanted to share about an in-depth interview study we did with 12 young Aboriginal people in the first few weeks of the program. And again, the lack of females represents the smaller number of females in the program at the time. and 19 key informants. There was a number of staff and elders and other people we spoke to. I mean, so it wasn't elders. We couldn't get one of the elders because they'd moved to somewhere else, but we didn't have anyone in the staff at the time who identified as Aboriginal and or Torres Strait Islander. There was an uncle there for a while, but he'd moved to another workplace and wasn't contactable. And we had 5 external key informants, including some Aboriginal health professionals, young people who were on our Aboriginal Advisory Committee to look at some of the qual data with us. And we tried to take a strengths-based approach. So we wanted to think about what was it that enabled young people to stay in the program and to have good outcomes from the program, rather than looking at deficits and talking about what are the problems and challenges. And we drew on the Healing Foundation's definition, which has subsequently changed since we did the work, but this is the definition we used, which is that recovery from psychological and physical impacts of trauma requires healing. And for Aboriginal people, trauma is predominantly associated and a result of colonisation and government policy. It's not an outcome or a cure, but a process that's unique to each individual. It enables individuals, families and communities to gain control over the direction of their lives and reach their full potential. And the idea that healing continues throughout a person's life and across generations. And lastly, that it's underpinned by a strong cultural and spiritual base. So this was a real driver for our analysis. And even though it was in the healing definition, it was also very evident in our data that all of the young people we interviewed and the perspectives we got from the different stakeholders, particularly our Aboriginal Advisory Committee, Aboriginal health professionals and Aboriginal young people that were advising us, was that every young person that comes into these programs has a unique experience, and we can't just have a cookie cutter approach to their pathway to healing. Another really important thing that came out, that even though 3 months sounds like a long time, the physical space they get for healing by being in this residential program that's away from the chaos of their lives is critical for their healing. And that may be why there is this overrepresentation of Aboriginal young people in a residential program as opposed to maybe an outpatient program. But I think for all the young people I've had a lot to do within the NOFS program, the physical space becomes a really safe space for them. Even the one that's based in Sydney, that's in a small townhouse with not much physical space, they're physically away from the chaos of their lives. It's also about psychosocial time and cultural and spiritual aspects to that time that they need for healing. We have to look at all of those aspects, not just you've got a dependence on drugs and alcohol, it's also about those other dimensions of the young person. One of the challenges for NOFS and many other programs, both mainstream and Aboriginal community controlled, is how do we provide collective healing and look at the collective health. And in Aboriginal and Torres Strait Islander conceptualisations that I have learned from my Aboriginal colleagues over many years and continue to learn, is it's not an individual concept in many cases, although everyone's unique again, but for many of the young people we spoke to, their health and well-being was inextricably tied to their family and their community. And again, we can learn for non-Indigenous young people from what Aboriginal young people told us, that when you're an adolescent, of course, your health is going to be tied to your family because you're often dependent on them, much more so than an adult coming into treatment. But we don't do enough in any of the programs to connect and engage with family and community. And there may be issues in those communities and families that need support and attention. So we can't just provide support for a young person and then just throw them back into a community that hasn't been supported or a family that hasn't been supported. And lastly, that there's an ongoing journey. So many of these young people come in and out of treatment, and we've seen that in some of the data we looked at about the number of times young people come into the treatment program, leave after a few days, come back again, etc. So it's an ongoing journey where the after or continuing care, support for families and in community are critical. And so really echoed the Healing Foundation. So what that means is it's critical, and we're not doing a good enough job of it. And I'm sure if Rob Sterling was online, which maybe he is, but NADA, which is the New South Wales Alcohol and Other Drugs organisation that represents service providers, has done a lot of work around Aboriginal and Torres Strait Islander cultural knowledge and practices and how they can be better embedded at an organisational level. So it's not enough to just employ Aboriginal and Torres Strait Islander staff. And we know there's major workforce issues in the sector. So we're having troubles retaining all people. I think there's a lot of workforce issues generally, but for Aboriginal and Torres Strait Islander workers in drug and alcohol, it's a major challenge. Some of that's related to pay, but some of it's probably also related to lack of cultural safety. And there needs to be partnerships. We can't expect every organisation to do everything, but we've got a lot of really, really powerful and influential and amazing Aboriginal organisations out there. And there should be more partnerships between mainstream and Aboriginal community controlled. So Resi Rehab's done really well by NOFs, but maybe the partnering more sort of formally is a way forward for mainstream services. As I said before, employing Aboriginal staff. If young people come in and they don't see staff that are Aboriginal, you know, they're going to leave. And clearly that's happening. And it's got to be a culturally safe space, not just for clients, but for workers. And I'm pointing the finger at us in academia. We need to work on that. And we are. A lot of academia is quite culturally unsafe for Aboriginal and Torres Strait Islander people. And programs, as I said, need to seek out those long-term relationships, but that includes Aboriginal elders. Some of the experiences the young people we interviewed shared were about the time when the program did have an elder that was working quite closely with them, and they'd go out on country or go to smoking ceremonies, and that impact on these young people was massive. Some of them had never really had connection to culture. So some do and some don't. I guess forward looking, this isn't the end of the line for this kind of research, and I don't know whether any of you in the audience are doing similar kind of work. I've been doing a lot more work in refugee health as well lately, using linked data and again qualitative work. But the colleagues and the team who worked with me on this work, Andrew Hayen and a team at UTS, but also Rob Sterling from NADA and Danny Manton and others from ADAN, the Aboriginal Drug and Alcohol Resi Rehab Network. We want to do a similar thing with them because this is based on a mainstream service. So what would we find if we look at an Aboriginal community controlled or Aboriginal, not all community controlled, but a very strong Aboriginal kind of board and influence on the programs? So again, we want to look at linked hospital and Bureau of Crime stats data, but I don't know how many of you know about PLIDA. I can't remember what the acronym means, but it's ABS data that's now much more accessible to researchers. So we can look at things like education and income. We can look at more strengths-based analysis. So what happens to people who go into drug and alcohol treatment? And this will be an adult study, by the way, from 16 and up, or 16 and up are a lot of the program entry ages. So what's happening for Aboriginal people going into what are more Aboriginal community controlled Resi rehabs? And we've got, you know, looking at their pathways over time, again, using linked data, which removes the problem of difficulty following up. And also the research we're hoping to have funded will have a capacity building element. So how do we help the ADAN members to improve their own data collection and reporting, both for quality improvement, but also to show to funders what they're able to deliver. And we're also looking at doing a client journey mapping part to the work in kind of a co-design way. So there's some of the papers, and that's pretty much all of the talking I wanted to do because I'm really keen to hear from all of you and similar work that you might be doing and hearing about any questions. So do you want me to stop sharing my slides now, Fiona?
Yes, please. Thank you so much, Sally, for that fantastic overview. Such a huge program of work and a lot of important findings in there. At this point, I'll like to invite Phil, our panelist, to turn on his camera and microphone, if you'd like to join us, Phil. Hi, thanks. Welcome. Thanks for being here.
Thanks for having me.
Before we get into questions, and just a reminder to everyone in the audience, please feel free to drop them in the Q&A box, and I'll try to get through as many as I can. But before then, Phil, I wondered if you would like to offer a bit of a reflection on the overview that Sally has just presented.
Yeah, I mean, I think I'll say one thing, and that I'm coming at it slightly biased because I work primarily in a primary prevention space, but I found the crime trajectory is a bit depressing.
Mm.
It seems like this intervention, if you view it as an intervention, this program was having an effect on the really bad people, like the people with really bad trajectories, terrible trajectories in terms of crime statistics, and bringing them back to a still bad, but just not quite as bad. And it just, I'm like, are we getting them too late? How can we get them earlier?
Can I just speak to that, Phil, because it's a really good point. Ted Nofson, we came up with an idea of a skateboard during our time together. So, you know, they fall down this abyss and we get them back out again as best we can. But I'm giving a big shout out to Ted Nofs. They also have a program called the Street University, or the University of the Street, that actually came from Ted Nofs, the grandfather of Matt Nofs, who's now the CEO. So basically the street unis are probably the thing that government's funding more now than the resi treatment. We still need the resi treatment, but the street uni is basically getting young people who are at risk of getting into trouble early and getting them into a university of the street where they do music and rap dancing and art, and they have access to counselling. So there was one in Mount Druitt, there's one here in Randwick, there's one in Canberra. They've now had 2 new ones open in Queensland, funded by the Queensland government. So that's the early intervention component, because I couldn't agree more. It's too late, but we still know that there's some young people we can't reach in time to prevent. But absolutely, that early intervention should be where we put a lot of our dollars. You might want to say more. Sorry, I just wanted to.
No, I think I'm glad to hear that the programs are there. I'd love to hear more about those programs. It does. So are those programs new?
No, they've been around a very long
Okay.
time. And actually, Joanne Bryant here at UNSW has done a lot of collaborative research with Ted Nofs about the trajectory of young people who've been to the street uni. So if you search Joanne's name in Google Scholar, some of her work would come up. And they've done some really creative things to get data from the young people, because the last thing a young person who's been in trouble with the police or isn't going to school or whatever wants is someone, as they walk into a service, to start collecting data from them. But they've managed to do a really good job of getting some data about what happens, and the findings are really good. Hence why they've had more funding for programs in places like Logan in Queensland, which has got a really high crime and youth disadvantage problem.
I think that was my main reflection anyway.
Okay.
Fabulous, really, really interesting insights, and so great to hear about sort of the diverse range of programs and platforms that are available for this population. We do have a couple of questions, and just to acknowledge, Sally, that there's thank yous and just comments on the amazingness of the research that you're collecting and how difficult it is to establish that entire program. So that is well warranted. One of the questions relates to sort of the healing program, and you'd mentioned at one point that the measures that were used were not validated for Aboriginal and Torres Strait Islander participants. Are those measures available? Would they be intended to be used if the study was to be replicated, or future similar studies?
Yeah, I mean, obviously the administrative data isn't using a survey, but the surveys obviously had standardized, validated. So you've got arguments for, because they're psychometrically validated scales, but the arguments against are that they're not appropriate. But the program obviously is more than just Aboriginal young people. But I did want to see, there's a thing called the growth and empowerment measure, but it's really difficult to do that unless it's face-to-face. But there has been a lot of work done to develop more appropriate tools that are young people centered and also culturally and appropriate. And if I was to do any other work in the future using a survey, I would definitely go down that path. But we were a bit hamstrung by what the program had already used at baseline, because we were using their baseline data that was their existing program. But I do think the sector needs to think about how do they measure change, and even going beyond just obviously Aboriginal and Torres Strait Islander young people, but culturally and linguistically diverse. So thinking about the nature of their client base and what are the most appropriate measures, because we know that a lot of measures that have been developed in psychology, which is my original background, were probably developed with men over 40 who are white, so they're not even appropriate necessarily for women. I'm not saying all of them, but we do have a lot of psychological constructs and scales that aren't really fit for purpose in today's world. So there's a lot of work going on. I'm not developing new scales, but I'm actually working with one. I'm developing one new scale. I'm working with Anke van der Sterren at ATODA, which is the I never know all these acronyms. It's the ACT group like NADA that represents all the service providers for drug and alcohol. And Anka, through a doctorate, is developing a PREM, participant reported experience measure, for people to share about their experiences of treatment. And it's been driven very much by service users, so Aboriginal, culturally diverse, like lots of different service users, as well as service providers. So that's a step in the right direction, creating new instruments, but also drawing down on existing where there might be existing scales that meet a particular need, because it's very expensive to psychometrically test and validate scales. So I think we've got a lot of work to do, but there's certainly some really good work going on.
That's exciting. And yeah, a limitation of using sort of observational or routinely collected data is you've got what's been done, but important considerations moving forward for sure, and exciting to hear about the other scales work that you've got going on. One of the questions we have is, was there any qualitative measures on following people who didn't present to hospital after treatment? Kylie says they're very aware of shame, especially for First Nations people, and how that may influence them not presenting to hospital after completing treatment.
Because we didn't actually physically contact them, it was administrative data. So we sought ethics, including from Aboriginal, like AHMRC and other ethical bodies. It was a waiver of consent. So we didn't have consent. We did a linkage where we never knew the identity of the people's data we were linking. So we don't know the answer to that. Some of the 12-month follow-ups we did. So we did do some interviews, but it's hard. It's a small number. We could possibly, put forward some hypotheses, but we don't really know. I think it's likely that, there were some things coming from young people that they developed a mentorship relationship with someone in the program or someone they got connected with. So I think having a safe person post-treatment that they continue to work with, and again, that continuing care. And I think the next body of research really needs to look at the effect of contact with continuing care. So we tried to do that, but we kind of ran out of money and time, as you do in research. But we wanted to try and count the number of contacts they'd had with the CALM program and see whether that mapped on to hospitalisation. So we definitely have a very strong belief that continuing contact with the service or a mentor was probably a major factor in a young person staying on track and not ending up in hospital or with other harms.
Yeah, and that's, you mentioned PLIDA and the possibility to be able to focus on more strength-based measures, and I think that that's sort of another one that falls into that category. It's being able to also highlight the benefits in terms of the improvement versus not just the reduction in harms experienced would be really good moving forward.
Yeah, exactly. It'd be so lovely to say, look, they went on, the group that went to treatment or the group that accessed the street uni went on to go to education, and they ended up earning a better income, and they had a safe house to live in. Like, they're the things that ultimately, we should be striving for.
Most definitely. A few questions sort of around sort of the more Boxer and sort of criminal sector of what the results you were presenting. Did your research find any connection to family violence?
We didn't look at that. So yeah, there was just, as everyone knows working, there's truckloads of data and there's so many questions you could ask. And I wish we'd had more funding, but it was a linkage grant, which I don't know if any of you have gone for ARC linkage grants. You're tied to what your partner can commit. So NOF's put in cash and in kind, but it meant the budget could only go so far, which I think is a real problem. But it's just the reality of funding. But yeah, it would be really interesting to look at that connection. Definitely, I think that there would be, there's a lot of trauma in this group. And there was a question in the TED-NOF's baseline, which is about experience of violence. And a lot of these young people have experienced violence either in the home or with outside of the home as well. So there was also a lot of violence with other persons not in family. So there's definitely a lot going on here. So that's why I think the can't just focus on the young person. You need to think about family, community. You need to think about that broader context in which they're nested.
Most definitely. And again, on convictions, was there any information on what types of convictions the young people in the study had?
There was other work on that. I haven't got any slides on it, I don't think, but I'll just go down to that, just remind myself which of the papers it was. So yeah, there's some stuff about the type of crimes, so violent and non-violent. But yeah, look, there's just so much more we could have done with the data. And I just hope in the next tranche of funding we're going to have, it's not an ARC linkage. So I hope we have enough funding. We're certainly going for more to be able to do more work with the data, because, you know, the time it takes to link and get ethics, there's just so much you can do with the data. So I guess I encourage any of you looking at working with linked data, and I know there's many people in NDARC that do, you know, funding. I mean, it feels like, oh, we'll just link the data, but the time it takes to clean and analyze and think about it, like the data's not neat, it's pretty messy. So yeah, I would love just to do a bit more on the types of crime, but yeah.
Yeah, most definitely. I mean, I think your program has pulled so much research from these projects that you've described here today. But yeah, even so, there's always remaining questions or strategies for improving the linkage in the next sort of round. Just on the acronyms, which I'm similarly never as good at remembering, the Alcohol, Tobacco and Other Drug Association for the ATODA.
Yeah, thank you.
When mentioned. Yeah,
Uncle would not be happy with me that I didn't know what it meant, but anyway.
We can go back and fix that up. From Jane, we have a question. You mentioned contact with CALM. Were there some people who had more than one contact with CALM? If yes, did this align with outcomes?
We didn't do an analysis by number of, you mean number of times they went to PALM or CALM?
I think that you'd mentioned it for CALM and the question is related to PALM.
Okay, so what if they'd been to PALM more than once, they're more likely to be connected with CALM? Is that the question?
Not sure, Jane, if you want to clarify that point.
I'll just tell you the analysis we did do. We did do some
Yeah.
analysis because we were interested at one point and it didn't show anything. If they came more times, like they left and came back again, was there a cumulative? And in fact, there wasn't. In fact, the more times they came, the less likely it looked like they were going to have a positive outcome. So that could again be more about the person and the problematic nature of their drug and alcohol issues, or the family environment or community environment. But we did do an analysis looking at length of stay, and we found various lengths of stay were related, you know, had an impact. So I'm just quickly opening up that paper because again, I couldn't share everything. I'll just quickly go to the conclusions because I think this is an interesting one. It was published in Drug and Alcohol Review. So we looked at duration of stay and rate of subsequent criminal conviction and hospitalisation. And the bottom line was 30 days or more in treatment. This is the violence thing as well, was independently associated with a lower rate of conviction for any offence and a non-violent offence, as well as hospitalisation for substance use, while 60 days or more was associated with a lower rate of conviction for a violent and admin offence related to those offences. So it's quite complex. You'll probably have to go and read it, but we looked at months in program, time in program, and the different types of conviction. And so it looks like up to about 60 days is good. Beyond that, there's not much additional benefit. So 2 months is probably a sweet spot, but there needs to be more research around that in terms of treatment. But definitely coming back and forward to treatment, like dropping out and coming back, tends to actually be a negative for outcomes compared to a positive. But definitely we think that the connection with CALM, but there needs to be more work in that. Like, how does a continuing care program sustain the impact of a 2 to 3 month program that's intensive? And that's really, for me, the area of future research that should be a focus.
Most definitely. It's the quality, or just as much as sort of the quantity, like, yeah, as you said, the repeat, and we've seen similar stuff with opioid agonist treatment as well, that regular short contacts, like not properly engaging, but coming back regularly is not always a good sign, and begs the question sort of what are the strategies that can be done to sort of improve that engagement? Where are things not working for that individual?
Yeah, and should they be going to a different type of program? Is this really the right program for them? But maybe it's the only program, and that's the problem again, that they're coming back because there's nowhere else to go.
Yeah, most definitely. I would second what Kelly has said, which is that it seems a bit of a pity that mainstream media doesn't advise the general public of this great work, and whether she's referring to the research program that you're talking about, or the programs that the NOS that NOS has. I would second that. I mean, yeah, working in this space, some of the programs and even the ones you were describing to Phil are not familiar to me. So it's great to know that this research has had impact. The findings have translated to impact in the actual community. There's probably even more push to go.
Yeah, we did get some media. I mean, it's the old story, isn't it? The media loves a bad story, not a good story. But we did get second page of the Daily Telegraph. Matt Knopf's had some contacts, which is really different to get the Daily Telly saying something positive about drugs and alcohol. But yeah, we have gotten media over time. We had a piece in The Conversation that got quite a bit of traction. But thinking about drug policy and drug treatment, investment, it's a long game, isn't it? And obviously the Drug Summit, which has recently occurred, has been a real opportunity to try to influence policy. And I guess we're still to see whether that actually results in more funding for treatment, which I suspect it will, because that's an easy win rather than decriminalisation or another safe injecting room, but I should remain optimistic. Or safe consumption room. Look, I think it's always about trying to get the positive story out to the media and out to the community, and it is hard. They just love running, ice addict trashes hospital headlines. That gets someone to read the paper more than kids have a great experience at Tednall Street Uni, or culture matters. Yeah.
I don't know. I'd be picking up those papers with the letters.
I know you would, but I don't think we're the norm, unfortunately.
No. Look, I will note we have just a few minutes left, and we do have a couple of questions. One that I think would also be interesting to hear from your perspective, Phil. I'll go to Sally first, but in relation to your own sort of work in the alcohol and other drug treatment sector or prevention sector. So what is, and you alluded to this a little bit, Sally, in your conclusions, but what is the potential to scale up this program, and other programs, or are there other programs able to be evaluated similarly? So, either in the research sector or, gaps in the types of programs available for either prevention or secondary prevention. Thoughts around that?
Well, I think the TC model itself is quite an internationally well-known model, but I think the modified version of it for adolescents certainly has a lot of value. But I think if it was to be in the Aboriginal space, for example, it would need to be modified to be more culturally and driven by Aboriginal people. But there certainly is a lot of things to scale, and the Street Uni is obviously scaling in that it's being funded in more and more places. But again, that model, which is a little bit like PCYC, the Police Citizens Youth Clubs, to a much more funky, larger degree, like those early intervention things where young people have access to activities and programs and things that are, just in the community. And I know that it's needed, in many areas. Like I've done some recent work in La Perouse, and there's not enough places for young people there, Aboriginal and non-Aboriginal, to go to do activities and things. So I think there's a lot of things we know from this work and much other that we could scale. It's just the will of government and funders to say, we haven't just funded it now and it's shown success, great, let's go on to the next great thing. It's about funding these things in a sustainable way. I'll throw to Phil.
I mean, I think I've maybe two comments on this. One is that I wonder about, well, like obviously it would be nice to see things scaled, but to a certain extent, some of what we're talking about maybe in some ways shouldn't be scaled, in the sense that what we want is really for Aboriginal communities to be developing their own interventions, to have control over them, not to just take a program that works in Sydney and say, do this, it works here. So actually, we don't necessarily want to scale the
good point.
intervention that works, but maybe we want to learn the lessons from that intervention and apply those in other places. There's historically been great work done by thinking work done by, say, Anthony Shakeshaft in the alcohol treatment, where they've taken principles of intervention,
components or principles,
let them develop their own kind of ways to use those principles, and that works really nicely. But the other thing that I would say is maybe that just to note that we're in maybe a unique policy window where crime is so on the agenda right now, that maybe this is, if there is ever going to be a time to scale this up, maybe it's now. So I hope that that we do see progress in this, because like particularly especially in say the Northern Territory, where we have both like real crime problems and also drug and alcohol problems,
Yeah, interlinked.
that
Yeah,
solutions to that problem like that are
community led,
terrible,
and that are community led.
that are
Yeah,
community led, that what
yeah,
might actually work. The only problem, I guess, is that whether they're like the community led interventions, being cynical, may be great for the community and maybe more likely to work, but maybe are less likely to be sold to the people who have the power to actually pay for those interventions,
yeah,
and the people who are voting for the governments who would pay for those interventions. That may be a bit cynical from me, but I would hope, given that it's on the agenda, like maybe now is the time that we should be pushing. Hopefully, we can see these programs, if not scaled up, then the lessons applied.
Yeah. Can I just echo, as my last thing I'll say is it's the idea of the form that something takes versus the function. And I go back to, I think it was Penny Horrell, really old health promotion paper I remember reading in my early days, that, okay, the sort of things that we know might be coming out of this is you need mentoring, you need a safe space. So they're the things that need to maybe be scaled, but how they look and how it plays out, the actual form of them is different. The function might be the same, that there's a mentor or a safe space, but how it's actually designed is very much community-led and contextualized. Yeah.
Yeah, profound comments. The principles of what is working is what really needs to be implemented and expanded. I think that that's really great points to end on. Thank you both, Sally and Phil, for your time this afternoon. It has been an absolute pleasure. Just before we go, I'd like to thank you all in the audience as well for joining and engaging in this discussion. We have a break next week in our NDARC webinar series, but on the 22nd of May, join us for what will be a special edition webinar featuring our own Professor Rebecca McKetton and her team as they present some groundbreaking findings on methamphetamine withdrawal treatment. So they'll reflect on the process of the trial, the TINA trial that is in the stage of wrapping up, the experiences of the research team, with a view to informing the conduct of future trials and other intervention research in that space. 22nd of May, pop it in your calendars. And in the meantime, have a great afternoon, everybody. Thank you.
Thanks, Grana. Thanks, everyone. Thanks, Phil.
Thanks for having me.